So to continue with it, we'll start with the new session. It is on health insurance, making quality healthcare accessible and affordable to all. For this, I will invite our program chair and chair for this session, Ma'am Meeta Rajiv Lochan, Secretary Public Health Department, Government of Maharashtra. Ma'am, you are requested to please join us on the stage. A big round of applause for our program chair. Then I invite Mr. Sriraj Deshpande, Head Health Insurance, Future India Insurance Company. Sir, please join us on the stage. A round of applause for our speakers, please. Dr. Ramachandra Dattare Lele, Director, Department of Nuclear Medicine and PET-CT, Jaslok Hospital and Research Center, Mumbai. Sir, I request you to join us on the stage, please. Now I invite Dr. Abhijit Ghosh, Vertical Head Analytics and Networks, Bajaj Allianz General Insurance Corporate Limited. And our last speaker of the session, I invite Mr. Joy Chakrabarti, COO, PD Hunduja Hospital and Medical Research Center, Mumbai. So you are requested to join us on the stage. Now I hand over the session to Ma'am Meeta Rajiv Lochan.
Okay friends, welcome to everyone for this session. I think we'll follow a format of say 5 minutes per speaker. I'll kick off with a few remarks and then let's give much more time to the question answer session so everybody can participate. Friends, the theme of this session, making healthcare, health insurance affordable and accessible to all, is indeed very important for this country. And it is my belief that health insurance can indeed be a means for reaching universal health care. At least if we look at the international experience, insurance is the means which has been followed by a very large number of countries. And some have been successful, some have been not so successful, but invariably it's been a very important mechanism. Today, if we look at the Indian scenario, we find that actually other than the government-sponsored health insurance schemes, private health insurance penetration in the market has been very, very limited. And if we are to ensure that health insurance cover becomes more and more generalized, then I think the two very important things which the industry needs to do, whether they are servicing the government as a client or whether they are servicing the private sector as a client, would be first of all to bring down prices, and secondly to bring some transparency in the manner in which this industry operates. Until such time as they can achieve these two things of bringing down prices and bringing about transparency, I see a lot of difficulties in any expansion in this sector. If you look at the size of the sector in India today, it's around 23,000 crores per annum. Out of this 23,000 crores, government contributes about 1/3 of this kitty, that's about 8,000, and the remaining 15,000 is paid up premium by the private investor. But friends, if we are to compare these two, the government and the private family floaters, as I may call them, the order of difference of price is of several times. Let's look at the details. Government, for instance, I am running a health insurance scheme and in the state of Maharashtra, and what Maharashtra is doing, many other states, Andhra, Tamil Nadu have also done. We pay a premium of rupees 333 per family per annum, and the sum insured is 1.5 lakh per family. There is no cap on the number of members of the family, and most important of all, there are no exclusions. All pre-existing conditions are a country which is spending anything between 12 to 15% of their entire GDP on healthcare, and after that it's one of the most unsatisfied consumers anywhere. So why is that? Why should it be possible for the government to offer 333 per family premium, cover all pre-existing diseases, and for the private sector to charge 6,000 to 7,000 for the same product? I think that there are two main reasons which are responsible for this. It's not just economies of scale. The more important thing is that in the health insurance industry today and the health and care industry which services the insurance industry, there are no package rates for most conditions. There are no package rates, period. There are a large number of third-party administrators which negotiate these contracts, very big guys, MD India in the west, TTK in the south and so on, but they are simply not able to, either it's not important for them or they don't want to do it, whatever may be the case, but it's almost a complete free-for-all, I think is the word which I would like to use. They do have grades of hospitals, 3 different grades of hospitals mostly, sometimes the number of grades vary, but the same disease is priced differently, is paid for differently, often in the same hospital, and there are no general policies, there are no standards about how and at what price a particular patient is to be treated. Friends, medicine after all is a science, and we cannot say that it could cost anything from 10,000 rupees to 1 crore rupees to treat a patient. There are indicative lengths of stay which would cover 80%, 85% of all cases, and it should be easily possible to work out package rates for indicative lengths of stay. At least 4 different state governments in the country have already done it. Maharashtra has done it, Tamil Nadu has done it, Andhra Pradesh has done it, Karnataka has done it. Why shouldn't the private sector do that? So that is one thing, that the private, that there is no package rate fixed. And the second thing is that there is no transparency about what are the parameters in which a certain patient would be treated and a certain patient would not be treated. Again, it's a complete free-for-all. When we talk, and I have many friends in the insurance industry, when I ask them, why don't you link clinical protocols with any reimbursement request? Every single insurance treatment, there is a process of pre-authorization. You may have noticed whenever you go to a hospital, there's a small room for the insurance people. That's where they go, and they will send an estimate whenever a patient walks in for a cashless facility. So the invariable answer is that we are capable of providing treatment on a case-to-case basis. However, we are not capable of generalizing it into a general policy. I think that's absolute bullshit. If you are capable of doing a piece-by-piece evaluation, surely you are capable of doing a general policy. We've done it. We have developed clinical protocols. It's all there on my website. Please go and see. And when we developed those protocols, we found that in the very first year, angioplasties went down by something like 20%. Now, I am not going to say anything about what the inference of that is. Does it mean that there were unnecessary procedures happening earlier? I don't know. But what I can see is that minimally, irrespective of reduction in the number of procedures, definitely general protocols do help to bring some transparency in decision making, which I think is very much needed in medicine today. We did nothing special, no magic. All we did was we asked the best doctors in the country to come up with these protocols about establishing appropriateness of use. And it has been reasonably well received. Until such time as we are able to achieve these two things of transparency and protocols, I think it will be very difficult for the private sector, whether it's servicing government clients or private people, of inspiring any trust in the patient. Most people that I know are so wary of buying any insurance cover because they say, how do I know? A gets treated, B doesn't get treated, A gets the full package, B gets half the rate. What is the reason for settling a certain bill for 1 lakh and settling another for 1.5? No, there's nothing. There are no parameters any which way. So my suggestion to all of you is that unless we can bring an end to this free-for-all and have some transparency, some rationalization, any amount of increase in the kitty, and the kitty is going to increase. Invariably it's going to increase. A certain one estimate says that by 2020, 80% of the country will be under some cover of some kind. But if the private health insurance industry continues in the same fashion as it is doing today, then I can assure you that the majority of that market will be held by government, not by the private sector. Is this what we wish to achieve? I think we need to certainly look at that case, and I would once again like to say that there is scope for a lot of reduction in prices. Till 10 years ago, a heart bypass in Bombay used to cost 3,80,000. Today, after 2 years of this Rajiv Gandhi Yojana, prices have come down to 1,75,000 for the general ward. I'm not talking about small 3-star nursing homes. I'm talking about Jaslok Hospital, Bombay Hospital, best hospitals in Bombay. So there is a lot of flab in those rates. We can address the issue. Let's see how to do it. Thank you. Okay, now I would like to request who
Good afternoon, everybody. I'll run through this presentation. I would not, let's leave the deliberations to the question answer session. I'll take exactly around 10 minutes for this. And we can very well have two major aspects usually involved in healthcare financing, in the entire healthcare sector. One is healthcare financing and the other is healthcare delivery. The major models which are being adopted across the globe, predominantly tax funded, predominantly social insurance based, predominantly voluntary insurance based. First one is where out of the taxes you pay, government pays to the third party providers. It's UK, National Health Scheme, or in Canada where you have a system where it is. Or you have the sickness funds which are social insurance based, just like cooperative societies you have the sickness funds which work on this. And then of course the insurance based. In countries with tax-based or social insurance-based systems, people supplement the entitlement with private insurance. Private insurance can also be alternated to public systems. Private insurance affected to cover co-payment, deductibles required under the public system or cover services which are not fully covered under. So there would be a basic government scheme and something is the private insurance complements or supplements it. Europe, 95% of the population is covered under some sort of a public health insurance coverage, 21% around mutuals and 11% PHI, private health insurance. USA, more than 25% of the population is still without any health insurance cover. Today you talk about Obamacare, you talk about everything, but it's still in a bigger mess. Fundamental causes of increase in healthcare cost, rapid medical technological progress, increasing demands for better care and aging population. Some countries partly attributed to rising levels of remuneration for medical personnel and practice of defensive medicine. It's very difficult to measure the rate of medical inflation. On a thumb rule basis, it's around 14 to 16%. India is the highest spender on healthcare related to its income. The health spending in absolute terms is still very, very low, $30 per person. Again, Indian demographic situation is totally different. Non-governmental healthcare has outstripped the role of governmental healthcare, amounting to about 3/4 of all finances for health, and most of which is by household as of out-of-pocket expenditure. 2/3 of all spending on hospitalization is done by private financing. Most of the household expenses are being met out of savings. Demand for healthcare is growing due to population increase, greater urban migration, increased per capita incomes, as well as increased expectations. Private sector in India is steadily increasing its dominance in health delivery, with majority of household health expenditures being channeled to it. The challenge is to capture a significant part of current household spending and assure that the total was spent on more cost-effective and high-quality services. What are the determinants of demand for health insurance? One is the public healthcare systems are failing or are inadequate. Higher quality of healthcare costs, Quality of healthcare service is perceived quality difference between public and private hospitals. Improvement in standard of living, improvement in level of education, aging population, supplier-induced demand. In demand economics, healthcare is the only one where the supplier decides how much of healthcare is required by the person. And increased penetration marketing initiatives. In India, health insurance is transacted by non-life insurance companies, life as well as specialist health insurance companies. What is the coverage there today in India? Rashtriya Swasthya Bima Yojana in 26 states covering around 35 million families and 120 million persons. When you talk about technology I think this is one of the most wonderful thing, where if people are aware how people get enrolled using biometrics, they are issued a card which is having the biometric of the person, the sum insured is stored inside it. The hospitals also have the card readers. The sum insured is there inside it, everything gets blocked, it's a paperless transaction. Today there are states which have started thinking about using this particular healthcare card for PDS distribution. Chhattisgarh has already started it, Karnataka government is also looking at it. To control the leakages in PDS, they are looking at actually uploading the PDS quotas into this particular card and giving card readers to the PDS. Arogyashree in Andhra Pradesh, Tamil Nadu government scheme 35 million, Rajiv Gandhi Jeevan they are targeting around 20 million, commercial insurance around 50 million. You have got ESI, CGHS, Railway Defence, all these captive schemes around 75 million. So we talk around 350 million, 26 to 28% of our population have some sort of a coverage. Health insurance premiums have grown from 741 crores in 2001 to around 17,620 in 13-14. By 2020, it's expected to be a 15,000 crore market. 60% of the market share is still by the PSU companies, expected to grow at 15 to 18% for the next 5 to 6 years. The growth in retail sector is still very low. A major portion has been correction in the group health premiums. However, the potential of growth is very high, but for insurance companies, the business is still a loss-making business. The loss ratios have been around 100% on just premium to claims, and combined ratio when you talk about expenses, etc., around 125 to 130%. If you look at evolution of health insurance, indemnity, just as beautiful, just hospitalization only insurance, then all expenses including outpatient, all comprehensive coverage, and then you go on to managed care. The products which are there, we know Mediclaim has become a generic name, then you have so many different, I don't want to go into details of this. Impact of health insurance on the healthcare sector. Growth of health insurance is going to give an opportunity to improve healthcare standards, especially healthcare infrastructure and accessibility to quality care. Will promote uniform standards of healthcare across the length and breadth of the country. Success or failure of any health insurance program depends largely upon the network and quality of healthcare providers. There is an immediate demand for such facilities. Can help remove urban bias and help develop healthcare infrastructure in rural areas. RSBY is a good example. A gentleman, a doctor, in one of those seminars, he said that the best thing schemes like this have done is that actually I used to practice in a particular hospital in Delhi and always wished that I could have my own hospital, but I could never invest in such. But I could, when RSBY started getting implemented, he said I went back to my place in town in UP, I could afford to put up an hospital, now I have patients coming there. Different and innovative products would become available. Growth of health insurance means increased standardized data resulting in greater usage of information technology in healthcare sector. Stimulated growth in pharma sector, increased manpower requirements in healthcare and health insurance. What are the areas to be addressed? Unregulated healthcare sector. We were talking about insurance companies having regulations. We have got a regulator for the insurance companies. We have got everybody, but this is one sector today. There is no regulations at all. So I think this is the right forum. Clinical Establishment Act is being brought in by the central government. 8 states have adopted it. We look forward, most of the states, if they try to adopt Clinical Establishment Acts, I think Maharashtra government should look forward and adopt it. And this is going to bring some sort of accountability towards this sector. Standardization of treatment guidelines. The first attempt for standardization of treatment guidelines was made by a FICCI committee consisting of insurance companies as well as doctors from more from the northern NCR region. Variations in prices for same procedure across different hospitals in different cities. Variations in prices in same hospital for same procedure for different patients. Hospitals have separate pricing for insurance and non-insurance patients. Easy availability of drugs without prescription and prescriptions without consultations. Unethical practices across healthcare industry. This is something I'd like to touch upon, just touch upon, because maybe we are quite early. Health outcomes. Outcome measures for quality improvement. Indian accreditation agencies are now emphasizing on incident reports, mortality reports, morbidity reports, surgical site infection rates, re-hospitalization rates. For insurers, if we go on outcome basis, better evidence through outcome measure leads to proper profiling of providers. Link payments to health outcome measures. help to differentiate between supplier-induced demand and evidence-based practice. Compare effectiveness of procedure used. A high-cost procedure might reduce need for recurring hospitalization. It is beneficial even for hospitals to use better quality. Research outcomes on relationship between cost, quality and health outcomes. Higher spending does not result in better quality of care. This is proven by research. Higher spending also does not result in improved patient perceptions of the accessibility or quality of medical care and their experiences in the hospital. In a payment system where provider incomes depend upon the volume of services they provide, patients in regions with physicians and hospital beds have more frequent visits to physicians and more hospitalization. Recently, AIMS has come out with something on the annual health checkups which are being there. As an industry, what has the insurance industry done? Health insurance, they have got in health insurance regulations, they have got TPA regulations, they have policyholders protected regulation. So one of the major stakeholders in this, the insurance companies and the insurance industry has got certain regulations in. We have standardized definitions, claim forms, pre-authorization forms, so many common definitions have been standardized. Standardization of data element has taken place. We look forward to move towards electronic transfer of data with the stakeholders. Consumer education and grievance redressal. We expect that now the industry, the provider industry also comes forward, joins with us. Just 8 years or 10 years back, when we used to have committees formed at the national level and providers were represented, they were hardly anybody would attend meetings. But now we see that people actively take part in all this. Days ahead, employers are worried about increasing healthcare costs and are forcing insurers to be risk managers and risk distributors. Insurance companies will look at cost control, which would mean utilization reviews. Cost control involves profiling of providers, doctors and physician education programs. Hospital groups and insurers would tend to get aligned for mutual benefits. Hospital would look at volumes and insurers at cost minimization.
Can we wind up now, Mr.
Yeah,
Deshpande?
just give me 2 minutes. I'll come straight away to what are the insurers' expectations. Medicines and consumables approximately form 25% of the bill in medical cases and 60% in surgical cases, especially when implants are used. More transparent pricing of implants and high-cost consumables. Patient does not have the option to buy them from a store and also verify genuinity. The patient is completely dependent on the hospital or doctor suggest implants based on the patient's condition. What is actually used during the surgery is very difficult to verify. The hospital buys stents or lenses in bulk at hugely discounted prices but bill it to the patient at MRP or even higher. Even if the manufacturer and hospital keep a decent margin, we can expect a reduction of 25% on cost of implants. Also, just like generics, the emphasis would be on indigenous implants and not promote imported brands. The last slide at this universal health suggested approach. You segment the population into affordability and insurability factors. One, A, who can afford and who are insurable. B, who can afford but they are not insurable. C, cannot afford and who are insurable. D, cannot afford and not insurable. A, go for commercial insurance coverage. C, commercial insurance coverage with government bridging the gap in affordability. B and D, government to bear the risk and insurance companies can administer the schemes. This is something like a health exchange. All stakeholders, providers, physicians, pharma companies to collaborate to make available most effective culture. Can we make basic health insurance mandatory if you want to achieve health for all? The slide is important because government keeps on talking about one large scheme over a period of years, 8 or 10 years. Such schemes don't work. Experience if other countries are, you get out of those schemes after 10 years.
Thank you, Mr. Deshpande. That was a very informative and effective summing up, I think, of the problems facing the industry. And now I request Dr. Ramchandra Lele, Director, Department of Nuclear Medicine at JSLO, to give his talk, please.
Madam Chairman, in the next 10 minutes I will make only one important point. In 2004, there was an Asian Health Insurance Conference and I gave the keynote address, 2004, and my scheme was health insurance as it exists is always making losses. And therefore, the only solution that I gave in 2004, add health insurance with preventive care. 1 rupee spent on prevention will save 5,000 rupees on cure. Unfortunately, 10 years have gone and not an inch of progress has been made, and still I have not lost faith. At the age of 86, I cannot make 5-year plans, I make 1-year plan. So with my PowerPoint presentation, if all the people here agree, before the end of 2014, we can have a workable plan in the city of Mumbai, which I call Mission Mumbai Health, where I have done a survey that the 80% poor people, they don't need charity, they need empowerment. Today, Dharavi patient, when he falls ill, in 1 week's time spends 10,000 rupees. I am giving for his whole family, for 2,500 rupees a month, I am giving a 5 years policy, and he pays 200 rupees per month through a self-help group, something which is workable. So unless we are very mediocre and stupid, there is no reason why within the next 6 months my Mission Mumbai Health cannot succeed. And I will give you the actual details. You please study the PowerPoint presentation and ultimately see what are the plans that I am giving you. I will give you actual agenda of how my scheme can success. Micro insurance and microfinance. Dr. Ila Bhatt has shown in the Ahmedabad experience that health insurance has to be within the mandate of microfinance, and I am looking for a microfinance company who will give me 6,000 crores tomorrow with the assurance that he gets 25% interest and in a 5-year period he recovers. I am waiting for people to come out with this scheme, and with 25% interest, which is a bankable proposition, but I will show you how. What are the characters of my scam? Each old man after the 60 gets a pension in my scheme. And I will tell you what are the features of my illness. I am suggesting that the Rajiv Gandhi Smart Card, which takes care only of hospitalization, which forms only 10% of a poor man's illness. So my bronze card will supplement your card, and for 200 rupees a month, for the next 5 years, the entire poor population of Mumbai can get health insurance with preventive health care from day one. What are you waiting for? What are my schemes? Ila Bhatt has shown very carefully that her plan is working very successfully, and I will show you all the features of my scheme in the next 5 minutes. C.K. Prahlad said, for the fortune at the bottom of pyramids. Dr. Velumani is going to be my partner in my health insurance scheme of preventive care, and he will help me to provide diagnostic tests for the bottom of the pyramid. And I have listed the test. He is my active partner, and he will see the potentiality. 23 million people of Mumbai. In 2011, I went to Taiwan. The entire population of Taiwan is 23 million. Every citizen has health insurance. He carries a card. When he goes to a hospital, his electronic record is there. But Taiwan is making losses because they have not added preventive care. So I told the Taiwanese that I am going to do better than you because I am adding preventive care and this health insurance card with preventive care, and I calculated that the 1,500 crores losses that health insurance company are making, and the 6% that is due to TPA, the 2,100 crores, I can pay one family doctor 1 lakh rupees per month for taking care of 1,000 families, it's 5,000 people, and I give him a laptop computer, he will have electronic records, the technology is there, the opportunity is there. What are we waiting for? Now, what are the salient features? Maintenance of continuous healing relationship of a family physician with a voluntarily enrolled population, one family physician for 5 to 1,000 families, to provide promotive, preventive and curative care for 3,000 to 60,000 individuals per week. For the family physician will get a monthly income of 1 lakh of rupees. He does not have to do unethical practice. Today the practice of Mumbai is so commercial and so shameful that I am allowing him ethical practice of medicine by taking 1 lakh rupees per month. Physician and multi-different specialty terms can design and execute best care. We do not need a TPA. The medical profession itself takes the responsibility. Hospital facilities, complex diagnostic equipment, laboratory investigations are deployed on a basis that can be used with greatest efficiency and economy. Electronic patient record and computerized prescription are part of my care. Every family physician that I am going to employ, I am giving a laptop. I am giving him all the knowledge base. And every patient of mine has a mobile. My maid servant, my cook, my sweeper has a mobile. So when he becomes my patient, through mobile communication, I can give contact with him and I'll send a reminder. You are a diabetic. Your next hemoglobin A1C due tomorrow. Go to thyroid care and get it done. Look at it, tremendous potentialities. We are so mediocre that 10 years this message I am shouting and still we are not making progress. So I feel that this platform is the best occasion for me to say that if you accept my plan today, before the end of 2004, we can have a reality of Mission Mumbai Health, and we do not need charity. The poor man is willing. I have done survey in Dharam, आपका कब आता है? 80,000 taxi drivers, 5,000 workers, आपकी policy कब आने वाली है? People are ready, and we are not ready yet. The approach is most effective in cost control. In the current free for service scenario of medical practice, new single source patent protected drugs are aggressively promoted by drug manufacturers. If I write a prescription of 30 rupees, I get 5-star hospitality to attend a conference. If I get 1 rupee drug, I don't get hospitality. So in my scheme, 350 essential drugs will be given at a cost, and that is one of the biggest contributions to the poor man's expenditure. 50% is drugs. So if I can give him drugs at a lower cost, that is the biggest contribution I will be able to make. So, okay. Impact of preventive care of lifestyle will be measurable with drastic reduction. By 2025, India is going to be the capital of metabolic syndrome, the largest number of diabetics, hypertensive, atherosclerosis. So if prevention can start today, we can prevent the diabetic capital 25. Who will do prevention? Family doctor. And let me know, 600,000 doctors of modern medicine, 600,000 doctors of Ayurveda, and 400,000 doctors of homeopathy, all can do preventive care. As a teacher of medicine, I can tell you that I can take the 600,000 Ayurvedic doctors and 400,000 homeopathic doctors, and I will train them to take preventive care. All of them are capable of preventive care. And with standard computerized prescription, I will see that they are. So manpower is not a limiting factor at all. A very important message here. A chamber managed care will not only ensure the elimination of the widely prevalent gender discrimination against females, it will actually put major emphasis on the care of the mother, female child, adolescent girl, example nutrition, menstrual hygiene, sanitary napkins, prevention of iron deficiency, sex education, prevention of STD, HIV, emergency contraception, family life education, women's, all can be done through my family physician who can be easily trained for it. So this is the most important message I am giving you. Care of pregnant women will ensure that no baby is born at a birth rate of less than 2.5. Unfortunately today, 60 lakh children are born every year with a birth rate of less than 2.5. These are going to be the diabetes and hypertension. So a very simple challenge which can be started today is to make sure that no baby in Mumbai is born with a birth rate of less than 2.5 by giving preventive care, something which is easily possible. So this is my action plan. Bronze card, 2,500 euros per annum. Through self-help groups, each member pays 200 rupees per month in a bank account. So in the next 5 years, she repays. Then she gets a new account. Something which is easily possible. And what do you get? Life insurance for the breadwinner. Accident cover and health insurance for everybody. Today everybody in Mumbai can be knocked down by a truck while crossing the street. So accident cover for every citizen of Mumbai is included in my plan. No exclusions, preventive care and pension for people above the age of 60, all included in this plan. Unusual features, preventive dental care, preventive mental care, accident prevention, blood donation directory. Velumna is my partner who will give me all simple tests for the bottom of the pyramid, not the middle rank. All these components are mentioned there. All the details are given here. So my urging to you on this platform is Mission Mumbai Health is not Mission Impossible. I know it is not a trip to Khandala, it is counting Mount Everest, but Mount Everest has to be climbed. So what are my partners? Jain Bhantia, ex-Chief Secretary of Maharashtra Government, Municipal Corporation of Bombay, Rotary Club of Bombay, Sneha Almeda Fernandez, Kevin Bhatnagar, who is an international specialist on pensions, who have promised me how the pension scheme can be implemented with the poor in Mumbai. Arogya Bharati, Swasthya India. So ladies and gentlemen, if all of you agree, the plan is very possible. Within the next 6 months, if the government of Maharashtra and Polytechnic place, this can become a reality. You can download my PowerPoint, study it carefully, but I cannot make 5-year plans, I make only 1-year plan. Thank you very much.
Thank you very much, Dr. Lele, for your very insightful ideas. And indeed, prevention is much better than cure. And I take this opportunity to inform the audience that the Maharashtra government has already taken a step in this direction by declaring a prescription-free program in all the rural areas of the state, in all government hospitals. 350 essential drugs are being distributed free of cost for the last few months now, and now we are making a beginning in the municipal corporation hospitals also. So we hope that through these measures we will take care of at least 40% of the retail market for medicine in the state. And definitely we can work together on the kind of ideas that you suggested. Thank you very much. Now I call upon Dr. Abhijit Ghosh, Vertical Head, Bajaj Alliance.
So good afternoon everybody. Actually half of my job was already done when Dr. Shiraj presented on health insurance. So I'll be trying to skip many of the topics or the content which I have put in my presentation, which already has been taken up by him. But the core or the crux of my presentation will be how we can make it affordable, what are the various roadblocks. But before that I'll be just giving a brief about how exactly is the health insurance scenario present in world and in India, the overall view. We are all aware of the fact that the GDP spend of India is quite low, as Madam had rightfully said that it's very much, if you compare with US and all, it's on the higher side, but for us it's on the lower side. But if you see the way the hospitals and all are being framed up in India, that is the tertiary care sector that is predominantly being run by the private sector companies, whereas the primary care sector is a mixture of both. So we have a big challenge of having a good collaboration between these two aspects. Another point that is a bother of insurance company is the average amount of the inflation that takes place. Though there is no published report after 2011 where the average inflation was shown as around 20%. So this is the average inflation which we are dealing on day-to-day basis, and that is a main concern for us. Why it is a concern? Because we don't know how it will be going on years to come, and how we will be pricing our policies when we are trying to come up with new products and all. If you see how is the Indian population behaving, the amount, the population is growing, but if you see the age group is also growing. So there is a good amount of people above 65 years of age group which are there who need treatment, and the way the lifestyle diseases are moving as such in the Indian scenario, the diseases which are of chronic nature, which are linked with lifestyles and all, they are increasing. If you see the data of around 2001, it was around 18%, now it has risen to around 24-25%. So this means the treatment which require higher cost are actually increasing more and more in the present Indian population. The funding gap is a major concern. people don't have enough money to pay for the to pay for the hospital bills. That is the main reason why what government has also identified, and I think that is the reason why so many government schemes as of now is being floated, though they have their own criteria of exclusion inclusion, but yes, it is somewhere bridging the funding gap. It is somewhere assisting the people to pay the money. Otherwise, in the previous or in the past, the experience was like people were forced to sell their lands or jewelry, which still now is being done, but the frequency has come down on that aspect. If I see what is the main driver for health insurance in India, the predominantly there's a huge medically underserved population which needs insurance because they know that the cost of medical bills are rising, and they know that the paying capacity is increasing because there is a big amount of demographic transition that is taking place in the Indian scenario. The per capita income is increasing, and people are now started to earn at the much younger age group, which was not present in the initial day. And also they know that the lifestyle diseases are increasing, and the people who are more on the dependent age group are having, they are actually prone for treatment because the average life expectancy is also increasing. So all these are the major growth drivers which actually is promoting health insurance. Health insurance in the previous years was not a dominant force. It was sold along with some other insurance cover like fire, property or marine. But as of now, if you can see now, you are able to see standalone insurance companies also coming into the market because there is a huge potential of this area, and especially with government coming to the picture, the amount of money that is being funded into this healthcare segment is huge. To just tell you about how exactly health insurance companies fared in the last year, they finished at around 19,000 crores. The pie is around 58% for the PSUs and around 42% for the private companies. But if you want to look at the factor that is called as the affordability, what are the main drivers? See, for affordability, you need to have volumes because then only the pricing will come down for per unit person. Government has the power to drive volumes because they can impose the schemes, and I think this is the right forum where we can present our view, so that if something can get implemented at even Maharashtra level or at Pune level or Mumbai level, it will be fantastic because health per se is a state object. The industry also noticed that there are so many variables that are associated with the health insurance industry and all, and that is why our regulatory body, that is IRDA, that also understood the importance of reinventing the health insurance sector. That is when they introduced the concept of health insurance regulation, which though was imposed, but it actually helped us in cleaning many of the things that were not identified or that was not brought to the notice. There are other type of integrations that are going on at sporadic level, but I think if these people partner with the insurance companies, it will be a lot helpful. Things like standard billing format for an integration with HIS, or even on the aspect of electronic health record, because for insurance companies also it becomes very important to know the exact disease condition of the person who is about to buy the policy. If it is on a government platform, then since the exposure is to all, then the chances or the frequency will decrease. But in case of a selective insurance like the retail policy and all, since only specific people will be taking, if the insurance is sold to only diseased population, then the principle of insurance per se will not be met, because it is like I am spreading the risk to the pool of people, and then we are giving the money to them at the time of the treatment that is needed. CDEC and all are also working with IRD and all, where they are looking at the aspect of collaborating the HIS and the EHR so that the insurance people get the correct amount of data. The present day challenge is the inflation, which I have already mentioned, and we are also at a mercy of the hospitals in some cases, because there is no regulator as such over the hospitals which can define the laws and all. I'll just elaborate on this aspect in the next slide. Also, there is an increased amount of health insurance fraud that actually is a big deterrent in going for the affordability price, because people who are not expected to claim, they are claiming, and that amount of money is going to fund their wrong claims, which is again resulting into the increase in the treatment cost and all. And what Dr. rightly said about the preventive care services, as of now there is no proper wellness plan or the preventive plan that has been sought about in any type of insurance policies that actually has a negative aspect. So if you see challenges, what we feel from the insurance company point of view towards the hospitals is because of the lack of regulator. There are lot many mispractices that are going on, for which we also don't have a control, because for the patient who is claiming, it is the doctor who is treating him, and he will blindly follow the doctor or what the doctor is saying. So the type of hospitals the doctor is referring to the patient, that is still not it is not defined, and as an insurance company we have not reached to a stage where we can say that you have to go to this set of hospitals only, and if you take treatment to other set of hospitals, it will not be allowed. There is no benchmark or reference for hospital pricing. Like for insurance, if we have to clear any pricing, there is a lot of actual calculation that goes around, and then only the pricing slab is defined. But for hospitals, it is if there is a dollar rupee devaluation and all those things, that is the reason which they quote to raise the price, or it's done on the ad hoc basis. So if it is in that way, then it is very sorry scenario for the insurance industry to tackle this type of challenges. Also, with this advancement of the science, we see lot many treatment modalities which get used, which are generally not warranted for or not asked for. For example, robotic. Yes, if it is a cancer treatment and all those things where you need precise cut, then we believe that it should be used. But just for the sake of using this type of treatment, it should not be utilized or used. But the way the scenario is there in the present scene, people are wanting to use these services. It has become like a fad for the people. Again, published tariff concept. Today, if we have to go and buy something from the market, we do a lot of shopping. We see the MRP tag being shown, highlighted in the shopping malls and all. If today I have to do a shopping on the website also, I see all the tags, and it gives me or my team a fair enough deal or fair enough idea to know what is the exact price of any product which I have to buy. But this is not the case in the healthcare sector. To know what is the price tag of this doctor to this surgery, or to do a same surgery from other hospital, there is no published guideline. So if something on this aspect can be worked around, or if it can be enforced by the ministry, then yes, it will help in bringing more affordability, because now the person will know this is my sum insured and this is the price tag which I will have to pay. Then let me try to go to a lower set of to a different set of hospital rather than going to this hospital. So, and the standard treatment protocol. As of now, yes, the government or the state government has floated some standard treatment protocol, but it is at the discretion of the hospitals whether they can follow it or not. So, madam, it's my request. We have gone through the treatment protocols. I think you had put up a mail to Bajaj Allianz CEO also, and we went through it, and it's wonderful. But the only part is, what will insurance company do to enforce the hospitals to follow that? Or but it's all distributed.
19,000 crore तरी वापरायला पाहिजे.
That is very true. But yeah, that is other. So it becomes if the center or the state government enforces the hospital that, see, if you have to practice, please follow the standard protocols, then it becomes easy, and then it is the right way. So we would expect that type of support to make it a success. So I hope that madam comes up with some type of guidelines soon for us and the hospitals.
For the state, they should adopt it.
Exactly.
हम लोगों ने अपने लिए तो किया है, आप लोग करिए ना adopt. My open invitation to everyone.
We are very happy, but since the hospital is not regulated, so there is no binding on the hospital side to follow that.
We are trying to build up consensus on that. Very important point. And let us see, something about a CA Act is in the offing. How long it will take, I cannot say. Yeah.
Thank you, ma'am.
Thank you.
Yeah, and the other challenge which we are facing from an overall industry point of view is the fraud aspect, and all over the world people are losing money. From India also, yes, there is about 20% of the cases or the payout that is taking place is pertaining to the claims which were not meant to be claimed. What it results into, because it looks like a very small topic, okay, fraud has happened, but see, these people get out from doing or getting caught properly because there is no documentary guidelines where we can highlight that this person did fraud, because KYC still now is not mandatory in the insurance sector. So since we don't have any proper identification mechanism, it becomes difficult for us. There are few initiatives that have been taken by the GI Council where the data sharing is taking place, but it has to go a long way ahead. The flip side of this is that it results into losses for the insurers, it results into premium hikes, it results into putting caps on the various policy level conditions, due to which insurance is not taken in a positive way by the customer. From Bajaj Alliance, we are very strict and we are very strict on dealing with those aspects, and we are doing lot many FIRs, and we are putting lot many show cause notices to the doctors and the hospitals whom we have caught doing fraud and all, and we were successful in getting license, the practicing license getting cancelled from the MCI for 2 doctors, that too in Maharashtra. So this is the way how we are dealing, and the fact is that we want to cut down on this type of leakage that is taking place. And yes, wellness and preventive things should be highlighted or should be taken up in a very positive way, not only by the insurance company but by the people also who want to avail those benefits and all, because just like sir said that 1 rupee can save the treatment, can save the cost by 5,000 rupees, but there's a published there's a published literature by Harvard University which says that every dollar invested into a wellness program result into a $3 saving in the subsequent outcome. How to identify? Yes, there are wellness firms and the companies who specializes on this, and they know how to manage that. So once the costing and all that day gets covered, yes, the affordability can be made possible. We are also striving at the unexplored market, that is the rural market and all, and hence since the government is also exploring those options, the tying up with a good government organization, with a good organization is really actually is the key that is needed. For the government, what I would say is that if they have tie up with those type of companies who have their own in-house claims management capabilities, it will be much better, because ownership becomes much more for the both of the organizations. So the main way how insurance company thinks about how things should be taken is lower the pricing, but without creating awareness, lowering the pricing will not have any impact from an overall perspective. Tax benefit, if we say buy insurance for tax, but then how many people come under the tax purview? The businessmen and all those things, they don't come under that. So we are not targeting, or we are not able to get in the volume game by targeting this type of benefits. If we want to give OPD coverage or some add-on coverage, but again when the awareness is not there, this becomes a very specific issue. Will they be using it? We don't know. And again, wellness and VAS, very good concept, but orientation and utilization almost nil. So we really need to build on insurance awareness. We want to improve the basic facilities to help the customer, and we have to work all those in a proper legal and a regulatory framework. At the end, we have to keep the customer in mind, because if the customer is happy, if the customer is being tapped properly, affordability and all is very much possible, and that is how many of the successful concepts have been working in India. I'll just like to end with the key takeaways. What I have from this presentation is, with key focus towards a universal health coverage, I think the focus will lie that how insurance industry and hospitals really join hands together to deal with the people, because the bulk and the volume will come. They should have a proper alliance, and they should have full transparency, because there is a lot of trust deficit as of now between the insurance companies and the hospital. Regulators should be introduced. The function of the regulator should not be just to see, oh, you are doing this wrong. No, it should be introduced to bring a common platform where the insurance industry people and the hospitals both can join, data sharing can take place. Also, the success and the failures of RSBY both should be taken in a positive way, so that the new scheme which gets introduced, which will be covering a lot of people, it should be done in a proper way. And then combating the fraud, that is again very important. The payer and the provider both again should join hand in sharing information to the maximum to combat this type of menace, so that again the loss ratios decreases and the affordability increases. And then try our best to switch from patient care to preventive care. Now, just like the finance minister yesterday had declared the budget, so we see people have been getting, now what would have been the tax initially will now come down by 30,000 or 50,000 or maybe 1 lakh. But tell me frankly, did any one of us thought that, okay, with this saving, if I invest only 1%, I should do a preventive health checkup, or I should I should increase my health policy, sum insured? I don't think anybody thought about it. Because health, though everybody wants to be healthy, but not through insurance. They feel that, why should I buy insurance? I will be healthy, nothing will happen. But he will not do any type of preventive health checkup scheme or anything to remain healthy. So this is the chicken and egg and a cross of the 69 situation. So this is how we are dealing with it. Thank you.
Thank you, Dr. Ghosh. You have highlighted some very important issues for the health insurance industry, including the issue of insurance fraud and of focusing on customer care services. And now, with so many inputs from the government and the insurance industry, I turn to Mr. Chakravarti, who will give us a perspective from the provider side, Mr. Chakravarti is Chief Operating Officer, Hinduja Hospital.
Which was left on the dais, and everybody has spoken whatever they wanted to say. Thank you for giving me the opportunity at the end, because tailenders come at the end and they hit six and win the game. So let me share my views, and I know all of you are here since morning, so my presentation doesn't have much text and heavy material for you to share. I have very few limited slides where I want to share some of my thoughts from a, not from a provider side. It is mainly to balance the relationship between the insurance company, government, agencies, as well as the private operators, public operators. And the topic is that quality healthcare accessible and affordable. So what I try to do, I try to see that whether really healthcare insurance company, they think in that line, whether really it goes like that. See here,
adopted and said where PF type contributions are allowed, and they get tax benefit for it, and that actually helps the person to utilize that amount what he saves judiciously for medical purpose only, and he gets a good interest. It's just like a PF account, and he tops up automatically with a higher sum insured, higher deductible individual sum insured plan. So that is where the cost gets controlled. People are working on that. The first point I just wanted to react, Madam, I think the government should not shirk off their responsibilities of regulating the healthcare sector. This is required from the central government, this is required from the state government. There is no two parts for it. Insurance sector has regulations, and insurance sector is well regulated. Healthcare sector is not regulated. Please do not ask insurance companies to regulate the healthcare sector. The way US model started, where they had to then get in regulations to correct what they had done wrong. HIPAA had to be gotten. For a very simple example I can quote, that a lady, how a regulation had to be changed in US was, a lady was discharged after 1.5 days of her cesarean section, because the insurance company's protocol was to discharge it with the best of this. She went into complications. It became a big court case. After that, under HIPAA it came in that at least 3 days or 72 hours of this thing, a minimum time the person has to be kept. But if we try to allow, I'm an insurer, I could have vested interest in saying, we should allow that to be done. But for the country as such, if we have to say, do not allow the insurance company, do not make the insurance company run the healthcare sector, I think that may be detrimental on a long-term basis. Get regulations. Government's duty is to regulate, so government has to regulate the insurance companies, regulate the healthcare sector. Do not ask one to, on a volume base, regulate the other.
Any other question? All right, in that case, I'll wind up this session. I would like to thank all participants for very learned presentations, and I think that was a very useful discussion with many insights for future policy. Thank you all.
I request panelists to stay there for a memento giving ceremony. Thank you a lot. Thanks a lot, Ma'am Neeta Rajiv Lochan and other esteemed panelists for a very wonderful session on health insurance. I request Dr. Ravi Gupta to present mementos to our eminent speakers. To start with Ma'am Neeta Rajiv Lochan, Secretary, Public Health Department, Government of Maharashtra. Mr. Sriraj Deshpande, Head Health Insurance, Future General India Insurance Company. Dr. Ramachandra Dattatreya Lele, Director, Department of Nuclear Medicine and PETCT, Jaslok Hospital and Research Center, Mumbai. Dr. Abhijit Ghosh, Vertical Head, Analytics and Networks, Bajaj Allianz General Insurance Corporate Limited. And Mr. Joy Chakrabarti, COO, PD, Hinduja Hospital and Medical Research Center, Mumbai. Thank you very much, and a group photo, please. Thank you to the speakers. And after this session, we will be now starting with the award ceremony. The Maharashtra Healthcare Leadership Awards 2014.